Good morning or good day. I'm glad to welcome you to a panel discussion on sustaining sexual and reproductive health access from emergency preparedness to responsive systems, hosted by the Interagency Working Group on Reproductive Health Training Partnership Initiative. Today's panel and Q&A session are part of the 2020 virtual IAWG meeting and are being recorded. We want to thank you in advance for your patience as we learn and experiment with the virtual format of such meeting. For the time being, we are asking all participants to ensure that they are muted and to please introduce themselves and share your questions for our panelists using the chat box. The chat box is being moderated and questions will be shared with panelists and participants as we move into the Q&A session. My name is Halyna Skipalska and I'm Country Director in Ukraine of the Health Right International, global health NGO dedicated to empowering marginalized communities around the world to live healthy lives. I'm also Executive Director of the Ukrainian Foundation for Public Health, a local Ukrainian NGO founded by Health Right. I have more than 18 years of experience in working for and leading non-governmental organizations in Ukraine, providing services to women, children, and youth with a specific focus on sexual and reproductive health. Today we have 3 panelists who will discuss issues across the sustainability spectrum. Yes, sorry, please mute your speaker, yes. From planning to providing comprehensive sexual and reproductive health services as part of emergency response to health system strengthening and transitions from the immediate crisis to long-term support, drawing from their experiences in Bangladesh, Pakistan, Ukraine, and Yemen. So I would like to welcome Sarah Ashraf, Reproductive Health Advisor, Emergency Save the Children. Sarah has been working in the humanitarian field for the last 20 years and with Save the Children since 2004. She has worked in long and short-term emergency response with Save the Children in Darfur, the Philippines, Haiti, Libya, Yemen, and others. She also leads research in protracted humanitarian situations and work on health system strengthening in fragile settings. She currently supports SAVE's emergency health program in Yemen and Pakistan with specific focus on reproductive health in emergencies. Dr. Alina Akhyar, Health Coordinator and Team Lead, COVID Response, International Rescue Committee, Pakistan. Dr. Alina Akhyar, as a public health expert specializing in health system strengthening, maternal and child health care, family planning, and reproductive health in program development and project operations management and coordinations. Technical advisor including team management and coordination, the Vaccine Alliance, USAID, Nutrition International, Mountain on Mercy, RQ, and others programs. I also would like to welcome Dr. Syed Rubayet, Country Director IAWG Bangladesh. Dr. Syed is a medical doctor with extensive experience as a technical leader, research and manager, and leads IAWG's work in Bangladesh. He is a public health expert in reproductive, maternal, newborn, and child health program and policy. Before joining IAWG in 2017, he worked as a program director of the Saving Newborn Lives program with Save the Children in Bangladesh and with the World Health Organization's immunization and polio education program in Bangladesh. Before we move to such important and very interesting presentations, giving the floor to the panelists, I want to say a few words about Ukraine and our conclusions and experience from work in this country. In 2015, in response to the acute humanitarian needs of vulnerable women and girls in east of Ukraine, Health Right International and Ukrainian Foundation for Public Health joined the UNFPA-funded program aimed at strengthening the national GBV prevention and response system at the national and regional levels to ensure that the majority of gender-based violence survivors have access to good quality survivor-centered care. Together with UNFPA and UNICEF, other partners, we contributed to building the GBV response mechanism in 5 conflict-affected eastern regions of Ukraine, strengthened and improved standards of national policies and legislation, and helped to establish a multi-sectoral coordination mechanisms at the national and also local levels. Usually, about 25,000 women and children benefit every year from our services and program. Our first conclusion was that it is very important to trace and understand the relationship between sexual and reproductive health and gender-based violence. The women can go to the gynecologist and domestic violence will be detected. Therefore, it is very important to properly refer the client to GBV and sexual and reproductive health related services, such as psychosocial support and access to contraception, STI, HIV testing, especially in the context of the conflict or in case of provision of sex services, for example. The second conclusion from our practice is that it is possible to ensure stability and a nexus between purely humanitarian interventions and the transition to the phase of reconstruction and development. In the case of Ukraine, we did this because we immediately built cooperation with local authorities and a variety of service providers. And the third one is that the best results can be achieved when the humanitarian organizations, UN agencies, and civil society partners work together and think of how to build a sustainable program from the very beginning. Thank you and now I would like to give the floor to our first panelist. Yes, and to Sarah Ashraf, Yemen. We will speak about comparison between emergency and development response and preparation in 2 programs. Doctor, please. Yes, Sarah, we see you. I would like to ask my colleagues to share screen with presentation.
Yeah, hi everyone. Can you hear me well?
Yes, we hear you.
Thank you. Okay, so thanks very much, Halyna, for that introduction. I will be taking us through 2 projects that we currently are implementing still in Yemen. And I will give a little bit of history and a brief. Maybe if we move to the next slide, please. So I'll talk a bit about of course, the situation in Yemen, but then what our program looks like overall. And then within that program, how we have integrated family planning into the health system. And then I'll speak a little bit about the 2 different projects that we have. One very much development because it is a development donor, and then one very much emergency or humanitarian. And then maybe just a slide on some of our thoughts and lessons learned and questions that are still not answered. So Yemen as a humanitarian situation is considered one of the worst crises in the world. A protracted crisis, looking at about 28 million people who are in need of humanitarian assistance, and a large number of these need immediate life-saving interventions. We're looking at very complex situations that kind of intertwine, but within that overall complex situation, the health system that is only partially functional. A WHO assessment that was done a year ago showed that about 50% of the health system is partially functional, and therefore much of the population does not have access, and that is functional is through the support of NGOs, national and international, and the UN organizations. Now, within all that complex situation, since 2015, new things have been happening in this year, as is with the rest of the world. Of course, there's the COVID pandemic that came in. There has been increasing conflict to different front lines. The humanitarian needs have not been met because only about 18% of what was projected as a need for the year 2020 has been currently funded. So there is a huge funding gap. And then there are other threats for famine and other outbreaks as well in the mix. Next slide, please. Save the Children has a relatively large program in Yemen. So all the area that's highlighted in red, these are the governorates where Save the Children implements and implements with a multi-sectoral approach. So there is health, there is nutrition, there is protection, livelihood, education. So it's a multi-sectoral program. For health and nutrition, both and WASH are basically very much integrated for Yemen, and currently are functioning in all these 9 governorates that you see highlighted, about 64 districts. So currently the program supports 330 health facilities, a number of basic IMOC, comprehensive IMOC, and then the outbreak responses through the cholera outbreak response, the COVID outbreak response, and also diphtheria. Next slide. So I'll speak here, I'll spend a little bit more time here explaining how we integrated the family planning approach within the regular program that we had. So the 330 health facilities that are supported are mostly at the primary level and are mostly supporting the whole range of primary healthcare services. So not just reproductive health, but the general OPD, the EPI, the nutrition, the pharmacy, growth monitoring, infant young child feeding. So it's a whole range of services that are supported at the primary level. Now, what the program has done for family planning and also post-abortion care has integrated within that whole setup and strengthened the family planning and the post-abortion care portion of the primary healthcare facility. So in practical sense, as women enter and they go into the reproductive health unit, they're able to avail good quality family planning service and a good quality post-abortion care service with a range of methods and commodities available and a fairly quality counseling that they can have from the providers. So a lot has gone into this program in terms of training and mentoring those service providers, in making sure commodities and supplies are available, in making sure that data is looked at every month in order to pick up any issues and to also put in corrective measures and to ensure that communities are aware of the services and also are aware of the benefits of family post-abortion care. Next slide, please. So this emergency family planning post-abortion care program kind of started in 2012 with a very small amount of emergency response that was done in one governorate. And in 2013, we were able to get a bigger grant for this country program for 2 governorates, Lahaj and Hodeidah, so 16 health facilities, out of which 4 are hospitals, and the rest are larger health centers. We continue to implement this project through with all the interventions that I just mentioned with my previous slide. And then as we spent a lot of time at the health facility level looking at quality of care, we were also able to work with the district and the governorate levels in getting some smaller policy changes for the benefit of the project. Now, the learnings that we got from this project, we were able to, in 2018, we were able to leverage this to get a much larger grant with a development donor. And that grant currently supports 220 health facilities, mostly in the south of Yemen, so in Taiz and Lahaj and Aden. And this grant supports only the family planning component within these health facilities. So the health facilities, again, are fully functional. They have all the other parts of the primary health care services being provided, and then we strengthen or work with a family planning portion. Much of what we were doing in our emergency grant, much of the learning that we had with our emergency grant was transferred towards this development grant as we wrote the design, but in a much larger way. So where we were supporting district level, governorates level, in this development grant, we started to speak at the national level. We started to look at their guidelines for family planning, for supply chain management of commodities, looking at all the other interventions as well. Next slide, please. So some of them were looking at task shifting. In the emergency grant, we were able to do task shifting at the lower level. And that was a big step for us because we got permission from the governorate health authorities to allow midwives to do implants, to allow midwives to work with MVAs, to prescribe misoprostol. This was not something that was done previously. Now, with the capacity building that was done, the agreement was that this model would be tested and we would be able to look at how it goes and then transfer that knowledge widely. So with the development grant, we were able to take the same learning and do capacity building at a much larger scale. So not only do capacity building for all the health facilities, for the 220 health facilities, but also support governorate level training centers to make sure there were master trainers at the governorate level who were then able to train and to cascade at a much bigger scale. Supportive supervision was started with the emergency grant by utilizing cadre from the Ministry of Health itself at the governorate level. The same approach was taken and moved forward with the development grant, but again, with more discussions happening now for a policy change to ensure that that kind of supportive supervision can be applied governorate-wide for all the governorates. Now, there are some differences in the two projects that are very distinct to see. The emergency project was able, of course, to take into consideration the very dire humanitarian situation and support the health facility in terms of its operational costs. Whereas on the development project, we were not able to do that. So we were only able to attach within health facilities where that support was already being provided by another donor. Supply chain management, where in the emergency grant, we were able to do a lot of system strengthening at the health facility level for supply chain. It was a bit more difficult for us to influence the supply chain management guidelines or the techniques at the governorate level, which is now currently being moved forward at the governorate level, but with all stakeholders involved. So UNFPA, the Ministry of Health, and others that sit in the Reproductive Health Working Group. So these were kind of the differences. Both projects are still ongoing. The 16 health facilities that we support through the emergency grant receive a much detailed insight into quality and what service providers are able to do. And the development grant is able to then support much more at the higher level, at the policy level, and look to see a larger change, more scaled up and widely available for the governorates. Now, what was our learning? That's the next slide. And the next one, please. So in terms of what were we able to learn? I think there's a lot to consider here, and maybe not all the questions we were able to answer. But the bigger question for Yemen, it's very much a protracted crisis. It's very much a humanitarian situation. So how would we describe it, really? We're describing it as humanitarian, but we're still trying to look at development prospects because it has been in this situation since 2015. So the question is, do we continue for this many years just to do life-saving interventions, or do we look at development kind of vision that allows those interventions to be implemented in a way that could benefit the health system, that could benefit much more while also saving lives? I think that's a big question. And then what's our understanding of the nexus? So we talk about the emergency to development nexus. What is our understanding? Is our understanding that it's a spectrum and we have to go along it? The situation in Yemen has proven to be different, where in certain governorates and districts where we thought we could move into recovery and eventually development, very soon we found ourselves falling back into acute emergencies as things got worse with either a sudden conflict or now the COVID pandemic. So things have been back and forth. So how do we understand this as adaptive programming? Is that what we're looking at? Do we understand that in a situation where the environment is relatively calm, there's political stability somehow, then we work towards preparedness so that if we fall back into the emergency, we're able to manage it. Another question that was really interesting for us was, what is the donor understanding for this nexus? It was interesting to see how both donors had a set way of working. For example, with the emergency donor, we were not able to let's say do research that is population based or go for very huge policy changes and work at the national level. Those were things that were not really doable at that time. Whereas with the development donor, it was also not possible to support the operational part of the health facility like we were able to do with the emergency donor. So again, maybe the process of working or the ways of working are very much still divided with the emergency and development kind of sections. So the question is, would funding also consider a nexus and consider adaptive programming? Again, sustainability in a rapidly changing environment is also challenging. We know that if we're able to do something today, then tomorrow, if let's say there is a political upheaval and the authorities within the Ministry of Health change, so most of the decisions that were made a week ago go back to square one. So when we talk about sustainability in these environments, what do we look at? Maybe we realized that one way to look at it was really to focus on the systems that work at the lowest level. So at the health facility level, learning from that maybe at a bit higher level, but focusing on strengthening the capacity of the frontline workers and hoping that that could somehow contribute to sustainability later on. Again, our programs, how do we design our programs? We don't necessarily design our programs with a lens of the nexus or sustainability in mind. So maybe that is another way to move forward, is that the design phase is to look at really how do our objectives directly contribute to something that could further contribute into sustainability, or could further contribute into interventions being implemented in a way that they feed into a health system. I think I've mentioned a little bit on the spectrum and the sustainability, defining sustainability for strengthening a system in this way. And maybe there are aspects of health system strengthening with fragility, and health system strengthening also through maybe a localization approach, through maybe working with communities in a better way, that they can be aware of what their needs are, and also be aware how to influence a system in both situations, in situations where things are better off towards recovery and development, but also when things fall back into acute emergencies. Yeah, I think these were some of the lessons that we kind of looked at. We don't have answers to all the questions, but it has been very interesting for us to see parts and portions of the projects in both cases that are moving well forward, and the parts and portions that are still very, very challenging in the context of Yemen. Thank you.
Sarah, thank you very much. I would like to mention again that we will have a Q&A session after 3 presentations, so you can write down your questions in chat box to presenters. And now I would like to give the floor to another panelist, to Dr. Sayed Rubayet, who will speak about engaging government to ensure availability of abortion services for Rohingya refugees. Dr. Sayed. Oh.
Thank you.
Yes, we hear you, but we don't see you.
Yeah. Okay. I'll go for the presentation directly because definitely. So this is Dr. Syed Rubayet. I'm working in Bangladesh as the country director for IPAS Bangladesh. Dear colleagues and different audience of different development agencies, and with a special interest on the humanitarian crisis, I would like to welcome you on my presentation, where I will try to present the Bangladesh case study regarding navigating the crisis landscape, especially on how we engage the Ministry of Health and UN agencies to make abortion care available to Rohingya refugees in the country. In 2017, many of you may remember that an eruption of violence in Myanmar sent nearly 650,000 Rohingya refugees across the border into Bangladesh. And the influx of refugees was among the fastest in the world ever seen, and approximately primarily over 2 weeks, beginning August 25th, 2017, and after a militant launch, deadly ethnic cleansing in the Rakhine state to the Rohingya population, and they forced to leave their country. So naturally, women and girls also fled homes and their country. Many experienced terrible violence, and including rape and sexual and gender-based violence, and they arrived at camps in Bangladesh. Bangladesh was not prepared for this acute influx of a 3/4 million population in a shortest shortest period of time. So in that situation, in addition to the need of basic food, shelter, and security, women face unique hardship trying to prevent unwanted pregnancy due to lost livelihood, disrupted family structure, exposure to sexual violence, and interrupted access to sexual and reproductive health services. With this background, we may also uh, uh, remember that the situation is not an isolated situation all over the world. When there are an uh, humanitarian situation, any uh, uh, public health emergencies or any fragile situation, unsafe abortion become a challenge. And unsafe abortion occurs everywhere, but 97% of all cases occur in fragile and limited resource countries. Sexual violence, are you hearing me? Sexual violence in conflict zones uh, uh, has multifaceted and can include rape, sexual slavery, forced prostitution, forced pregnancy, abortion, trafficking, marriage, imposing fear and intimidation in times of conflict. As a result, unintended and unwanted pregnancies likely increase during displacement and in humanitarian situation, making the need of SRH service, especially safe abortion, even greater. So with this background, I will share the case study in which I will share the Bangladesh experience, how we work with the government, with UN agencies and other partners to introduce comprehensive sexual reproductive health services for, in an adequate humanitarian situation in the Rohingya refugee camps in Bangladesh. As all of you know, unintended and unwanted pregnancies likely increase during displacement in humanitarian settings, in refugee camps, increasing the need of sexual reproductive health services and abortion. But unfortunately, this service is not available in most of the humanitarian settings. A global evaluation of SRH services in humanitarian settings conducted by MSF in 2013 and found that out of 63 facilities, abortion availability was not, abortion service was not available even in a single health facilities. So, but in recent time, attention is growing around barriers to abortion as donors, NGOs, and other civil society organizations become more convinced of this need, and reports of sexual violence are more widely documented. But reluctance for truly change practice remain tied myths and lack of political will. And this was, or this is true for every country, every region of this globe. So while in 2017, there was an acute influx of Rohingya refugees in uh, late August 2017, UN agencies quickly expanded their local presence. Uh, Along with the UN agencies, INGOs also moved forward and joined with government of Bangladesh in the planning and implementation of service for the new refugees. In September 2019, at the request of UNFPA, IPAS joined the SRH working group to plan the SRH services, assessment, monitoring, implementation, and scale up of SRH services. And before that, we also do some informal assessment of the SRH services, including the menstrual regulation availability in Cox's Bazar, and found that MR service was available only in the district health facilities at that time, serving that district facility was serving over 3 million population. We found that initially there are lot of disbeliefs and lot of obstacles that abortion service may not be possible to introduce in an acute situation when the Rohingya people who are Muslim, and there are perception that they are very strict with the religious beliefs, and lot of misbeliefs regarding abortion persist among them. At the same time, a lot of development partners were not interested due to the restriction of the global gag rule. But in Bangladesh, immediate after our liberation war in 1971, we introduced abortion, first trimester abortion care with the name of menstrual regulation. And from 1979, it became a government government health program. And so the country have MR policy in place, and the services were available in the public health facilities and NGO facilities. So the policy environment for MR in Bangladesh also provided us a basis for exploring inclusion of MR service, which is synonym of abortion, first trimester abortion for the refugees. So we have discussion and negotiation with UNFPA, and UNFPA leadership at the time was very much open and enthusiastic, and was also have a deep feeling for the women, their rights, their sexual reproductive health issues. And we come with a partnership with UNFPA, and we start working in October 2017 to establish 6 facilities which will provide MR and post-abortion care services in and around camp. And later, we gradually expand the services with the support of UNFPA and also include the family planning services. And at present, 20 health facilities with the support of UNFPA is providing comprehensive MR, post-abortion care services, and family planning services. So from the very beginning, IPAS start working to build capacity of the NGOs and the development partners on MR, post-abortion care services, and contraceptive care for the IPAS supported facilities and for other NGO and government health facilities, and also introduce values clarification and attitude transformation tools through workshop to reduce the stigma related to abortion care services. Uh, IPAS also from the very beginning coordinate with the Ministry of Health, took their approval, brief periodically about the situation, and also took approval after briefing from the Rohingya Refugee Repatriation Council of the Government of Bangladesh. Also work closely with UNFPA, IOM, UNHCR to initiate SRHR services as per national protocols and guidelines, and with the permission of government, RRC, and also from IOM and UNHCR for their facilities. Gradually, the service expanded with the support of other donors as well, with UNFPA, the Pecker Foundation starts supporting us from January 2018, and this year from April, Global Affairs Canada also extended their support for the comprehensive MR post-abortion care services and contraceptive care services for the Rohingya refugees. At present, we are supporting 34 facilities directly through our partner NGO, Bangladesh Association of Prevention and Septic Abortion Bangladesh, and Reproductive Health Service Training and Education Program, RSTEP. But we also provide support over 35 health facilities by capacity building and other technical support to introduce comprehensive sexual reproductive health services for the Rohingya refugees in Cox's Bazar in Bangladesh. So our overall goal is to improve availability and accessibility of quality MR post-abortion care and family planning services from service delivery points for women and girls of Rohingya refugees in Bangladesh, and we have a specific objective to build the capacity of the service provider, including doctors, midwives, and family welfare visitors. They are also mid-level providers to provide these services, and we provide health system support in 34 health facilities that includes the commodities, availability of the commodities in a sustainable way, especially for the contraceptive care support from UNFPA and the Ministry of Health, and for other services like MR and post-abortion care services, which support from our donors fund to ensure the supplies, ensure the safety of the service provider and safety of the and respectful care, safe and respectful care for the client for MR services. We ensure trained provider in all facilities willing to provide SRH services, and as I mentioned, nearly 35 facilities with our support ensure the SRH services and into steps for stigma reduction. Our key activities include facility assessment and selection, establish a coordination mechanism, as I mentioned earlier. Also, we provide both side orientation and values clarification and attitude transformation workshop to have a stigma-free and positive environment for the services. We provide support for facility preparedness and logistics and training on comprehensive MR and post-abortion care services. We conducted some research regarding social behavioral change communication to understand the better way for communicating with the Rohingya community and develop as BCC material and took some community mobilization initiative in the local language. We to ensure the quality of the service, we provide support for site monitoring, mentoring, and also for quality data collection, reporting, and use of the data for program improvement and local level uh, action to improve the program. So we focus on capacity building, health system support, and provide MR tech services. We provide the VCAT training to the health management team leads of the Cox's budget, the facility managers, and also service provider. And initially, with the support of our global team, we developed a trainer school and also provide training in a continuous process so that the new provider can also have empathy about the services. Along with MR and post-abortion care services, as I mentioned, we provide support for contraceptive services, including long-acting reversible contraceptives. We also do advocacy with the government to allow these services, and UNFPA joined with IPAS for this advocacy with the government. There was initial controversy about the use of contraceptives, but later government agreed with that. And we found that there is a good opportunity to introduce the subcutaneous injectables for Synapres for the Rohingya refugees. And it is unique because when we introduced this DMPSC, Synapres for the Rohingya refugees, that time it was not even introduced for the country. And also, especially after the after a couple of months, we found that lot of women's with their different priorities, information gap is the opportunity to take the MR services, and they approach on the second trimester. And at that time, we took initiative with support of our global colleagues and the neighboring countries trainers. We organized initial workshop with leadership from the Ministry of Health, Obstetrics and Gynecological Societies, and because the second trimester post-abortion care services, there was, and second trimester abortion care service was never introduced in Bangladesh as a program. So we organized a training immediately when we become able to arrange the trainer so that the Rohingya refugees women can be benefited from the second trimester services. And ultimately, we become able to introduce second trimester service and second trimester post-abortion care services in Cox's budget. And later, it also helped the country to introduce second trimester services for medical legal cases and second trimester post-abortion care services in the country. We are in a preliminary stage. So this situation also helped us with our proactive response to overcome the challenges, at the same time learning for the country. And as the whole world experience an unprecedented event of pandemic COVID-19, we need to adapt, we need to understand our situation and adapt our interventions, capacity building, the service interventions with using the technology. Immediately we use the Facebook and create Facebook group and WhatsApp group with our providers, provide orientation to them, especially to regarding their safety by using PPE. They assured their mm, safety is a big issue for all of us, and we become able to ensure training link with the provider, with our trainers pool, and provide continuous support along with the logistics support. And also we make some changes in service provision. We become counseling and remote service provision via phone calls, promoted home administration of MIFI and misoprostol, that means medical abortion, and with an additional doses of misoprostol. We start promoting self-administered subcutaneous DMPA, and also use the social networking to provide support opportunities for clinicians and IT staff, as I mentioned earlier, through different social media chats, groups, Zoom, and Microsoft Teams. So with this experience in Bangladesh, we found that if we become strategic, if we need to address the real need of the women, we need to introduce the abortion care service as an essential service, and it is feasible in even acute emergency setting. It is important to do advocacy and provide updated information to the government, especially Minister of Health and UN agencies, and that can be a key to success. And post-abortion care and abortion care along with contraceptive care should be provided comprehensively. Awareness creation, quality assurance, adaptation is challenging but possible in humanitarian settings. Thank you. Thank you.
Dr. Syed, thank you very much for interesting presentation, for shared conclusions or key learnings, and thank you that you covered and shared with us COVID-19 related issues and challenges. Now I would like to give a floor to Dr. Alina Akhyar, who will speak about building the capacity of the Ministry of Health to deliver high-quality contraception and comprehensive abortion care in crisis-affected Northwest Pakistan. Dr. Alina, this floor is yours.
Hello, everyone.
Yes, we hear you.
Yeah, thank you so much, Lena. Thank you so much. I was just trying to get to share my presentation, but somehow it was just hanging up. But then again, I'll just jump into the conversation and try to share the presentation again. Thank you so much for the opportunity. And I will be talking on behalf of IRC's Pakistan's country program. So IRC is International Rescue Committee. And I will be talking in detail around our work related to reproductive health, and especially around contraception and comprehensive abortion care. Just give me 2 seconds and I'll try to share the presentation again. Bear with me. Thank you. So, yes, I hope it is visible at your end as well.
Yes, yes.
So, thank you so much. As you know, that I think we reported our first case for COVID back on 28th of Feb 2020. As of today, I think we are standing kind of at the next year where we are seeing COVID, a pandemic situation, where we are kind of working on mitigation phase, but at the same time, we're also working on recovery phase. Reason I want to kind of reflect together on our work around comprehensive abortion care and COVID situation is because of the fact that reproductive health services, and especially in context of primary health care and RH itself, are kind of undermined during humanitarian crisis or in situations like that of COVID. And COVID is an example that we can all learn from as well. We have done a few things at our end. Probably it took us years and years as in to get to the situation where we had learned enough in order to support the government and also our ongoing reproductive health programs on ground to be able to contribute not only in terms of RH, but also in terms of COVID response as well. So kind of reflecting on our work till date. So IRC has been working in Pakistan since 1980. But a lot of our work around reproductive health has been in place since 2011. So from 2011 to that of 2018, we were actually working on post-abortion care and dedicated family planning services. And we supported around 3 districts of Khyber Pakhtunkhwa province, which was earlier known as NWFP province. A little conservative as far as the other context of Pakistan is concerned. So during those around 7 years, we actually supported around 81 government health facilities. So that included basic health units, rural healthcare centers, CAD hospitals, district headquarter hospitals. And a lot of our work was actually around in terms of improving the availability of RH services, improving the quality of their services. So it can be around the provision of supplies. It can be in terms of improving the capacity building or capacitating the government-based providers. So that includes doctors and lady health workers and lady health workers and other paramedical staff as well. And then we exited these 81 government health facilities. So we sat together with the government back in around mid of 2018, and we realized that we have been working in these 81 government health facilities for quite some time now. And I think we have good repo as far as the community outreach component is concerned, relevant to these 81 government health facilities. And then again, on the other hand, we had built an interaction or a collaboration with the government where the government was in good position as in to take all these 81 government health facilities and kind of absorb them back, maintaining those standards and indicators in place. So what has happened with Pakistan was that back in 2011, we had a devolution. So we had a federal ministry, but all our health relevant work was actually trickled down to the level of provinces. So that means the provinces after that of 2011 were responsible for raising their own resources, for their own mobilization, for arranging the supplies, if I'm to talk about only in the context of health. So I think they also were in the process of learning on how to manage this on their own. So we had 4 provinces back in 2011. So in 2018, they realized that they're in a good position given the fact that they have had that technical backstopping from IRC for good 7 years. And they had learned on how to kind of manage the caseload as far as family planning or as far as post-abortion care is concerned. And then I think they were happy with the work. They have been able to retain 90% of our structure, which was actually handed back to them in 2018, because even now and then we kind of interact with the district health officers, we interact with the desired ministry to make sure that we kind of keeping track of the work and the effort that was actually put in on part of the government and also that of IRC for good 7 years. So kind of learning on from those 7 years, we again sat with the government and we realized that we do not want to have a very extensive HR structure in place where we are giving you the resources as in to hire people. Let's sit together and find a smarter way of doing our work in lesser budget, lesser HR support as far as the IRC side of component is concerned, and kind of more work on your part and more technical backstopping on IRC's part. So in 2019, we were actually handed over 2 more districts. So one was Peshawar and the other was Swat. So Swat had a lot of military operations starting from 2009. The process kind of led on to 2014. And then Peshawar has seen a huge chunk of refugees over the past so many years, starting from the Russian revolutions, even to as of date, because of the internally displaced population. So we sat together with the government and we were actually handed over 16 government health facilities. We kind of devised a model where we kind of upscaled our work from not only post-abortion care up to that of comprehensive abortion care. So we're talking about contraception, we were talking about post-abortion care, we were talking about safe abortion care as well. And all that in coordination with the government bodies, making sure that they're well informed and there's no gap. So when we leave, they're able to retain that structure. So as of date, I think until that of June, we have actually supported around 18 government health facilities in these 2 districts. And then again, yes, we have done capacity building, but not of our own hired staff, rather that of government engaged staff. So that includes their managers, people who are responsible for managing kind of reproductive health component, people who are actually responsible for extending these services on part of the government, and including their district health officials to make sure that they understand the significance of the reproductive health work. And then we have again worked on improving availability of services, accessibility, quality. So that quality not only includes improving their training technical component, but at the same time working on infection prevention control, working on wash level indicators, kind of integrating the component of minimal initial support package. So kind of making them understand that what it means to kind of run this entire model structure on their own, that is having an ING or an NGO as a technical partner. And then a lot of our work during the last 1.5 years was around values clarification. So we did a lot of sessions internally, making sure that our senior management team had an idea and still has an idea of what it means to kind of work on comprehensive abortion care, especially in Pakistan's context, given the fact that we are the 5th populous country in the world. And then at the same time, we started working with young couples, and most of all, a lot of our energy and time has actually gone into engaging adolescents. So be it girls and boys, we've actually tried engaging them with the understanding that these young girls and boys are likely to kind of become family members in maybe a few years down the lane. And we have had such an amazing feedback there as well. Knowledge management system, making sure of the fact that we bring all our learnings together in terms of our service numbers, in terms of community learnings, in terms of engaging religious leaders, becoming our ambassadors, talking about and kind of promoting comprehensive abortion care, and kind of understanding why it is of great and utmost importance that we kind of take this to the level of the community and not just at the level of the centers itself. And then kind of bringing in the element of integration, nexus or integration rather than integration. So we've worked at bringing together health in terms of comprehensive abortion care. We have actually kind of worked together with our WASH teams, which is actually working with another donor as well, and kind of understanding the concept of socioeconomic indicators as well. And then last but not the least, we actually realized that we need to kind of start hammering the government, especially that in that of a post-COVID or a during COVID situation, that why it is important to kind of reflect on our indicators around minimal initial support package. So I think we had a lockdown around 23rd of March. And on 23rd of March, the government, especially the provincial government, since post-revolution, they are responsible for running or kind of controlling the facilities. They actually advised kind of shutting down all the OPDs, including labor rooms. We actually realized in 2 days time period that this is the time to bounce back. This is the time to kind of work on the rapport that we have actually built in coordination with the government, and actually kind of reflect on our best practices and learnings that we've actually kind of pulled together from 2011 to that of 2019. And it is so vital to make sure that you have SRHR and even primary healthcare services available at the level of the health facilities. We did understand government's concern because it was an unprecedented situation. Even on part of the client, we saw lesser footprint or with the fear that they might get COVID if they walk into a healthcare facility. And then we sat with the government, we actually drafted a plan, and we realized that given the strategic priorities that you see on slide as of now, where we've been kind of hammering on their door, providing them the detailed technical assistance, kind of enhancing their capacities around health and social services, kind of making sure that up-to-date services and timely information is available, supporting with capacity building, mass sensitization, and kind of integrating the component of mental health and psychosocial support as well, especially in the context of COVID, and also kind of integrating it back to the concept of minimal initial support package as far as SRH is concerned, and making sure that we have money available as in to kind of sustain or support that work. So on 6th of April, I think, and after kind of having that collaboration internally within the organization, where we actually sat together, we realized that we will not be able to do business as usual. We will need to look after the health facilities, and we will need to make sure that our staff is safe and primarily our clients are safe, so that they can walk in kind of and get those comprehensive contraception, abortion care and family planning services, at least at our 18 supported health facilities. So a plan was devised, which was actually reflected as a master response plan. So the master response plan, the idea was that we are going to sit together and we're going to see what we can transition towards COVID through our healthcare staff, which was actually offering comprehensive abortion care services, and how we can use the same opportunity to kind of inform people on COVID situation as well. So that master response plan was actually backed up with a number of steps. So we sat together with the government, we kind of aligned our master response plan with all our outcomes. So it was not just health. So health, education, wash, power, safety, economical well-being, all our projects under the Pakistan's country program, they were aligned to this new COVID situation to make sure that we did continue, not if as business as usual, but kind of to realign ourselves to make sure that we understand this new normal. So for the purpose of ensuring that our SRHR services were immediately available, our staff was back on ground, properly trained on all protocols of COVID. So be it around kind of donning PPEs, ensuring infection prevention controls, how to make referrals for COVID, how to kind of support the government with contact tracing, what to do if there's somebody who requires psychosocial support. So that is in addition. So in those 7 or 8 days, that is what we did. We actually sat with our HQ. They were already working on a comprehensive curriculum around ensuring that those services are available. We kind of trickle it down to our own staff, and with their support, I think we deployed around 22 people back at the level of healthcare facilities. We kind of integrated the OPD component with the labor wards to make sure that women had access, or any other couples who wanted to avail antenatal care services, even primary health care services, or information, they want to seek information on COVID, that was being done through that one window, ensuring all precautions. So our country support team was there. There was a detailed orientation of staff. There were project action plans. So imagine all our projects that are being currently done, they had their project action plans that were aligned with this master response plan, and they had their risk mitigation plans. There was a detailed rapid assessment. So I think initially we did a detailed rapid assessment around health and other outcome areas in around 12 districts. So this covered SRHR services, and we actually realized there's need and people want to come back. And government also realized that we have been training and we've been kind of sensitizing ourselves around minimal initial support package that actually vouches for the fact that you need to ensure that during a humanitarian context, these services are readily available for your already vulnerable population, or even for your masses as well. And then there was immediate deployment of our staff there. And this was not, I'd be honest if I say, I'd be lying rather, that if I say that this was done in a day's time. So we had a learning from 2011 to that of 2017, 2018. And then in 2019, we were already kind of in talks with the government. We're like, how can we help you sustain this learning and this mechanism where you raise your own money, as in to ensure that these kits or these modality or these capacity building trainings are kind of integrated within your government system. So we did, since this was a key area of our intervention, and we realized that in Pakistan's context, where there have been disasters in the past, it is a very calamity-ridden area, it is the 5th most populous, and then we have seen the refugee population coming in across the border internally as well. We realized that this will be relevant to our context, whether we like it or not. So we did 2 evaluations with district health authorities, one in Peshawar and the other in Sawat, to kind of reflect on the district level capacity and the readiness to implement that MISP component. And I think it was very well taken by the government. And it was actually a holistic exercise where a global tool was used, a readiness tool was used, our own M&E team was engaged. We kind of had key informant interviews, not only with the provincial government officials, but also with the district officials, with doctors, with healthcare providers, even with our own staff. And at the same time, we even did focus group discussions with the adolescents group, and also separately with that of male, females, and that of young couples, to make sure that we understand what it means to kind of integrate minimal initial support package, and especially the component of comprehensive abortion care, God forbid if there's a humanitarian situation. And we never knew back in 2019 that COVID is right around the corner. But then again, that detailed exercise has actually helped us, because we had that assessment already done. And we had a few findings around contextual analysis, around the availability of supplies and equipment, around what kind of operational resources are available, what kind of mobilization is needed to ensure that this becomes a key part. So CAC and MISP becomes a key part of the government strategy. So I won't browse through the detailing assessment. I'd love to share the presentation afterwards. However, we realized, if I'm to summarize this, that at the level of the province, post-devolution, there was understanding that there is need to kind of have those vulnerability assessments in place. But then again, when we kind of trickled down that exercise to the level of district, we realized that they were not prepared. They were only referring to having those instruments or delivery kits in place, saying that we're prepared for minimal initial support package. And that's when we realized back in early 2019, that is, it's just training for MISP is not only for the level of healthcare providers. It's more important that we kind of engage the highest officials for them to understand that you need to either have a PC1, you need to have an action plan in place so that you can allocate resources to be prepared for it. And then again, the province, most provinces have an RH group in place, and they have been meeting regularly on a quarterly basis. But somehow there are a few partners, I think one or two, who have been kind of vouching with the government, with us, that we need to kind of bring together resources to kind of have MISP integrated under the banner of comprehensive abortion care and family planning, be it with the humanitarian crisis or be it without it. But you need to be prepared in any given circumstances. But then again, a lot of that focus has deviated time and again to other priority areas as well. So kind of bringing them back together. We had a very detailed tool. So just to give you a visual kind of presentation of the fact that if you look on the left side, you'll see that what kind of centers was visited. We had them kind of evaluated across all major indicators of MISP. So there was GB with gender-based violence. If you look on the other slides, HIV and STIs. Availability of safe transfusions, making sure that you have a core component or a core organization in place who can kind of bring all partners together, including that of government, to make sure that we are very aligned. So just to share examples of how detailed the assessment was. And then the exercise, after it was done, we sat together with the government. We had, until that of early 2020, we had an action plan in place around minimal initial support package to make sure that at least comprehensive family planning and contraception and abortion care services will be available in normal and in that of humanitarian crisis, and what needs to be mobilized in case, God forbid, if there's a crisis. And then because of that exercise, I think back in Jan, when we didn't know that pandemic is kind of seriously rolled down to Pakistan, I think that gave us the edge. As soon as we had our master plan in place, we knew what needs to be done. We kind of sat together with the government. We had a master response plan. We deployed our own staff. They were trained. They were already trained on the MISP protocols. And since the highest officials had an idea of what it means to initiate minimal initial support package protocols, they were also hands-on with us. And then we did see, as I shared earlier, so between that of 6th April to that of 28th of April, we did see a humongous decline in that of client footprint. And then that is where our outreach around CONCASE, or contraception comprehensive abortion care, and that of our hotline came into place. So we were reaching out to masses through robocalls, through IAWG, through mass awareness campaigns, integrating messages around COVID, but at the same time kind of reflecting back on our core strategy, which is around comprehensive abortion care, that we are open, we are readily available, give us a call. You can reach out to our healthcare providers. So all our deployed staff was 24/7 available. They had their own set of support as well. And they were available on kind of extending referrals, but at the same time giving hands-on services at the level of the healthcare facilities as well. And then we did see back and forth in terms of COVID. So we had a hospital where there was a bigger exposure. That hospital was shut down for 48 hours. It was fumigated, but then everybody was tested. They came back. So everybody was so proactive in terms of, and they knew that what it means, not only in terms of kind of serving cases around COVID, but kind of getting clients back into the health facilities, especially around primary healthcare and that of reproductive healthcare. We did have frontline workers who contracted COVID, but then again, that ratio has been extremely minimal because everybody was spot on trained from day one on what it means to ensure that all these infection prevention and referral mechanisms and protocols are in place. So this is just to reflect on the numbers that we actually serve. So imagine, as of date, I understand that our caseload has been very different than other countries, but we did see a peak in May, June, and that of July. And if you look at from that of April 6th to that of September 28th, so that is as of yesterday, we've actually served 3,441 new FP acceptors. So if you look at the other indicators, we have, and if you look at the major percentage of this, we had a very serious community outreach, mobilization, and risk communication and mitigation plan in place in April and that of May, and we saw people immediately coming back. We realized there's need, and making use of these numbers and that of our knowledge management system, we were able to convince government to open more government health facilities, kind of following our initiation of MIS protocols. And I think our team kind of led, and I'm proud of the fact that International Rescue Committee was one of the lead partners with the local government, kind of talking on minimal initial support package, given the fact that people were trained, informed, and already engaged, and also around contraception and abortion care. And if you look at the last slide, you can see the numbers coming in, regardless of the fact that we had peak COVID during those months. And then we did use other modalities around risk communication and community engagement with social media, WhatsApp, mobile vans, flyers, banners, and mosque campaigns were also used. We did realize that, and we have been realizing, to be honest, over the period of time, even with comprehensive abortion care, that your mental health and psychosocial support tends to play a huge role. And this evidently came across, especially in COVID situation, where people were either isolated or they had that fear that they might contract COVID. And if you look at our own society, we're kind of very heavily dependent on socializing. And the critique that came across in having yourself self-isolate, especially in that context, was not well taken. So we had a very detailed study, I'd say, done around mental health, psychosocial support, covering various indicators around health, around COVID, and around how do we see health in a post-COVID situation. I'd be happy to share that document because we have that out finally. And what's amazing that we actually realized that what has been most hit, or what is likely to get the most hit, is that access to basic healthcare services, especially SRHR services, and that concept of security. Or you lose, or in COVID's context, we actually saw a decline in that level of community and family support. So if somebody they've contracted COVID or they're positive, you immediately self-isolate. That concept is not, it's different on the paper, I'd say, and it's different when you do it in person. And then there's no formal, non-specialized or specialized mental health psychosocial support services available. So be it around with COVID or without that. And then we've actually seen our medical workers that have been subjected to such pressures, given the fact they're working in a high risk environment, they're wearing protective gear. So we had healthcare workers kind of donning on those PPEs, wearing those goggles, doing this day in and out, making sure that contraception and comprehensive abortion care services are available. And we saw them getting mentally exhausted as well, and socially too, given the fact that there were speculations, myths, and misconceptions around COVID and everything else as well. But then again, our master response plan guided us well, and definitely our work around comprehensive abortion care readiness. And then I think our experience, and we're just finishing this off, our experience, if I'm to talk about in terms of managing this situation, especially from a humanitarian context, kind of demonstrates that government is ready to work with be it humanitarian organizations or development organizations, and they want to build a very strong and sustainable system, including that of SRHR component. It is on their priority list. It's just that they need that technical help and backstorming and reminder that what needs to be done, when and where and how. And I think given the fact that because they see high staff turnovers, there's average technical workforce and then low financing, because we spend very small percentage of our budget as far as the GDP is concerned. I think that's something that we need to work on. We as development sector, humanitarian sector kind of builds upon that force. Even as of now, given our learnings, we recently had a session with UNFPA where we are kind of going back to the government, taking our learnings of what we did in terms of CONCASE, MISP, and that of COVID situation, to make sure that we have a PC1 in place so that government can kind of take these learnings to other provinces and other districts as well, to ensure that there's availability and accessibility of high quality services. Just a few snapshots of people who are actually of our own staff that was actually deployed at the time of peak COVID, kind of offering SRHR and contraception services and abortion care services. Happy to share these as well. So this is just a snapshot of our master response plan that was actually kind of reflected on a monthly basis. So thank you so much for the time. Happy to answer any questions thereafter. Thank you.
Dr. Alina, Akhyar, thank you so much for presentation about capacity building of the minimal initial support protocol and how it helped with the pandemic response, building psychological support into the response. Thank you for this presentation. So it seems like we have time now just for one question. So we'll see. Let's start with this one. How important is ownership of local stakeholders and partners when planning for sustainability of sexual and reproductive health rights services? How have you worked with local partners and particularly local governments to build that ownership? Dear panelists, can you share with us your thoughts?
Yeah, I can go for the question.
Yes, please.
Well, in terms of our projects, all our work was with the local district level Ministry of Health and also the key community influential in the areas that the health facilities were serving. So that it was clear that we could not have done this program without them. But other than that, also it has been interesting to note that in Yemen there are very strong national CBOs and NGOs that are very women focused and do a lot of work on the ground. So we have also been very engaged in our SRHR services with them. And recently we were able to do quite a bit of work also on the sexual violence front and integrating what the ministry was doing with a local partner. So it's very important to do that and to engage them, because that's where the ownership comes from. However, I think it's also important to do the homework really well, because it's clear that in a humanitarian situation, especially one that is conflict prone, there can be many other aspects in playing into these relationships between authorities, Ministry of Health, local NGOs, international organizations. It's very important to be well aware of those when bringing local capacity on board. Thanks.
Yes, thank you, Sarah. Dr. Alina Akhyar, maybe Dr. Sayed Rubayet.
I completely agree. If I'm to respond to the same question, that what matters is that you have the right people at the right place at the right time. So that kind of applies to engaging internal and external stakeholders. And we tend to kind of refer to NGOs, IANGOs, or CBOs and CSOs as stakeholders. At least in Pakistan's context, we even see community influentials, religious leaders as active and kind of contributing stakeholders as well. So I also agree that they definitely play a role and it is important to have them engaged primarily, if not from day one, at least as part of the design phase, so that there's ownership on their part, at least at the level of community.
Yes, thank you.
This is Rubayet. I do fully agree about the importance of partnership or engagement of the local NGOs, and especially to make it more comprehensive. Sometimes the engagement with the local agencies, local organizations who are involved with maternal health service or those organizations, in addition to providing facility service, have community presence. So this type of partnership, in addition to ownership and direct support to the service, it can leverage the presence of other organizations, and at the same time engaging the government is very much essential for the ownership, for policy support, and also to leverage their effort. Thank you.
Yes, thank you. Not sure if we still have time for one more maybe quick question. How did the work you have done on sustainability help prepare you for the COVID-19 pandemic? Now that's nearly a year in. What other preparation would you have done in hindsight?
Yeah, go ahead. Go ahead, Dr. Rubayet.
Please. Okay, okay. Thank you. So one of the key challenge for us is to continue the quality of care with the COVID situation. So with a sustainable approach, we make the arrangement that remotely with our mentors that can support the providers, we can arrange the training using some webinar, some remote audiovisual tools, and at the same time shifting from the services to more non-touch methods like medical abortions, self-injectables, and for the contraceptive, and also in trials, introducing trials in the facilities for the COVID-19. Thank you.
Thank you. Alina, Sarah?
Yes. Yeah.
Yes.
So I think I've kind of reflected quite a bit on it during the presentation, but then again, I think one thing that primarily worked for us was, a few of them have been shared by Syed, saying that we did monitor quality assurance using remote approaches and kind of provided supportive supervision using that online modality. But then again, having that master response plan in place to ensure that comprehensive healthcare services were available at least at IRC supported health facilities. So that had multiple indicators, quite a few that I've talked about during the presentation. Definitely, yes, the homework that we had done back in that of 2019, especially at engaging government around talking about comprehensive abortion care openly, and that of minimal initial support packets did play a huge role in kind of doing an active COVID response with that of SRHR services.
I would just add to what Alina and Dr. Rubayet have said. I think it's adding to those points. It's important that we go back to the front line. I felt like with this outbreak more than any other, if we had prepared our frontline workers in a much better way in terms of understanding in general what an outbreak is. This was, of course, on the extreme side, measures had to be taken. But other than that, just their understanding on how they could still support the community and continue to provide services with the confidence that they understand outbreaks, that they understand where they can put those measures in place, where they could be supported. Because again, at the end of the day, we support a certain number of health facilities, or let's say a geographic location with our projects. Those do well, but what about the rest of those, the country? What about the rest of the areas where we don't have functional projects that are being closely followed? So I think that, again, going back to system strengthening is really important, and ensuring that outbreak response preparedness is part and parcel of every department, not just the disease outbreak or infectious disease departments.
Yes, thank you. We are in time. So thank you very much for answers. And thank you very much, of course, to all panelists and to all participants who joined today us at a panel discussion hosted by the Interagency Working Group on Reproductive Health Training Partnership Initiative. Thank you very much for colleagues from IAWG who helped us with actually who organized this webinar. So, and I would like to add that this webinar was recorded, and the link, I hope, will be shared with all of you. So thank you very much.